Do we really have to do it this way? I'll bet you've heard that before. So it usually comes after the decision has already been made about implementing a new innovation. You've reviewed all of the evidence and you've made a commitment to moving forward. Then when you start implementation and almost immediately someone asks if they can change or simplify or combine or reassign or even eliminate a step in the innovation that you're trying. They're reasonable questions. In fact, often they're the right questions, but they are also some of the most important leadership decisions your organization will make, because every time we change an innovation, we make a judgment about whether this part or that part really matters. And sometimes, without realizing it, we end up changing the very thing that made it successful in the first place. Today, I'd like to explore how leaders can tell the difference. Hi, I'm Bruce Spurlock, a physician and healthcare leader committed to helping professionals and decision makers navigate change with clarity. On Viral Healthcare, we look at the ideas spreading across healthcare and what it takes to implement them wisely and sustainably. So today, I want to talk about a little bit more advanced topic. It's this idea of fidelity versus adaptation. Ooh, big topic, big words. We're going to talk about whether we need to stay true to fidelity or possibly adapt an innovation, an idea, a platform to meet the circumstances and settings of our organization. So let me start off with the hidden challenge. Most organizations don't really struggle to find good ideas. We've talked about that before. There are a lot of good ideas. You can see those. The question really is when you're implementing somebody else's idea inside a completely different organization, what happens? Are you ready? That's a topic from previous one, but more importantly, do you have different structures and different contexts that impact how the implementation or the even design of the project would go forward? Do you have different staffing? Do you have radiologists? Do you have dialysis machines? Do you use residents? Do you have staff that are exposed to different types of conditions and disease? Do you have a different culture? Do you have different resources? Do you have different patient populations? In total, what is the context, the total of the surroundings of your organization, all the factors that fit into it? Is it different than where the organization or the place where this idea or innovation was first created? So the question really is, at what point does adaptation become a different intervention? So this is the central tension between fidelity versus adaptation. It was very hot topic around 2010 or so, but it's still relevant today. If you have too much fidelity, if you try to be exactly like another organization, something might not spread, nothing spreads, or every organization is forced to copy it exactly, which may result in subpar results. In the whole scheme of thing. But if you have too much adaptation, then the innovation becomes something completely different. The goal is not to choose one. The goal is understanding which parts carry the weight, what needs to be at least similar enough to the original innovation, and which parts can be adapted. I want to look at this with two case studies, two different innovations that have a long history of both research on the effectiveness of the innovation and research on whether fidelity versus adaptation is important. So first case study, it's Project Red. This emerged around 2008, 2009 from a place by a man named Brian Jack in Boston, Massachusetts, and he studied this system that would reduce avoidable admissions. It was right at the beginning of the readmissions reduction craze that needed to happen in healthcare and still needs to happen. And Brian Jack came up with 11 factors that he proved in a very well-designed study made a huge difference on reducing readmissions. And so there was a lot of money, a lot of effort to replicate Project Red across the country. And these 11 steps, relatively simple to understand, but some had workflow abnormalities or issues, and some had resource issues like people. But organizations thought they better try it because there was a lot of pressure and eventually financial incentives tied to this idea of reducing readmissions. But the implementation dilemmas became very obvious early on, and organizations really started asking questions. Can we assign this task differently? Can we combine steps? Can we use existing staff? What about the workflows that Project Red identified? Can we modify those to meet our needs? They weren't really bad questions, but they were implementation questions. They were questions about importance of the fidelity of the activities involved. So the key lesson is that the smartest organizations didn't preserve every activity identically. In fact, it became pretty obvious that fidelity to Project Red was very difficult. And some of that was the setting that Brian Jack created in was different than most others. It was an academic setting. They had a lot of Medicaid patients, so a lot of structural things that were very different. But the smartest organizations preserve the function, or at least the effectiveness of the function. That's an important thing to remember. It's not just the way the function is or the step is that you're addressing. Is the replacement effective? A good example was the discharge coordinator. A lot of organizations didn't want to just have that be a position solely assigned to just that activity. Could we add it on to the existing nurse's responsibilities, or did it have to be a separate individual? And over time, the research said when you add this on to a nurse responsibility, it doesn't get done as well. And the effectiveness drops down. So this was one that you could adapt the type of individual that did it, the experience and background of the individual, the training potentially of the individual involved, but to add it on to a current staff probably wasn't going to work. So the question to ask and think about is, what problem is this step solving? And can we solve it differently without losing the effectiveness? So here's a phrase that we use all the time. We think that you should either adopt, adapt, or abandon. Let me repeat that. Adopt, adapt, or abandon. And you have to do it wisely. You have to do it thoughtfully. You have to really try to understand the ramifications. And that may mean looking outside of your own organization to a similar organization with a similar context and background. So, for example, an easy one is to adapt the form. You still have the major components of a form, but it might flow differently. It might have a look and feel differently because that's the way your EHR or your staff are used to it. You want to protect the mechanism. What is it that you're trying to accomplish? But you may adapt on the margins, on the fringes. We call that intelligent adaptation. The other side of intelligent adaptation is rationalized violation. What do I mean by that? It means that little by little, you start changing things. You start cutting corners. You start softening the edges. You start making it easier to try to get a specific step or activity done. Most implementation failures don't happen all at once. They happen one reasonable decision at a time. Everything is rationalized. You can defend it, you can explain it, and people say, yeah, it makes a lot of sense. It's sort of the death by a thousand cuts. When you add them all up, it becomes much more difficult, and the actual effectiveness of that implementation disappears. So, for example, if we're having regular meetings and we want to have a coordination kind of meeting, people start skipping one meeting because it doesn't seem like it's all that important and they're busy. Or you remove one staff position because budget requirements require that. And, one staff position, maybe it's okay to do that, but it adds up. Make one step optional, reduce follow-up. So in Project Red, it was making an appointment and making the appointment effective for leaving the facility. And if you couldn't get a hold of the doctor, you sort of reduced that or made that optional. Every decision makes sense individually, but this rationalized violation thing adds up, and then innovation really no longer serves the same problem. We could spend a lot of time in Project Red, really interesting. There's a lot of research. There's a whole thing from the Agency for Healthcare Research and Quality that was published on Project Red to really understand the components of it and some versions of adaptation that really worked. Okay, case study number 2. This is a fun one I was involved directly with. It was called the ABCDEF bundle. It's later renamed to the ICU Liberation bundle. And the whole goal was to get people who were sick and on a ventilator off the ventilator and out of the ICU much more quickly. The data suggested it was powerful. And a lot of research went into each element of the ABCDEF bundle. Each one of those bundles has specific steps, like trying people to breathe spontaneously and making sure you're choosing the right sedatives for them and doing early mobility, ambulation, even with somebody on a ventilator. So it was a very sophisticated but well-described, evidence-driven bundle that collectively, synergistically, seemed to have powerful, powerful effects. But different innovations behave differently. So whereas Project Red, the 11 pieces weren't necessarily interdependent or synergistic, ABCDEF was very different. Let me explain. Each component individually was important, but the components build on each other. So they reinforced one another. Pain management affects mobility. And if you don't do a good job of it, you're not mobile. And if you do too good a job at pain management, they're too sleepy to get up and walk around. Sedation affects delirium. Ambulation affects delirium. Family engagement, the F, affects communication and family participation in all these things. The value isn't just in the individual pieces, it's how the sum of the pieces interact and become a total activity. The ABCDEF bundle had great research that demonstrated increasing implementation effectiveness in each one of them had improved outcomes, like the lives saved, like discharge to home instead of a skilled nursing facility, like less delirium. So some innovations are additive. They're synergistic. They need to be woven together, and others you can make substantial adaptations and have similar effect. Removing one component in one setting would weaken several others. So it's important to think about this adaptation question. Let me give you one example in the ABCDEF bundle, a very good way of thinking about adaptation. So early mobility. Who does it in the organization? Is it the ICU nurse? Is it physical therapy? Is it assistants? Is it the family? You can, as long as you're doing that, whatever works in your organization is what works in your organization. And it may be combinations of those depending on the location in the hospital, location in the ICU, and the staffing that you have. So sustainability isn't about the finish line of implementation. It's really about the beginning. We start thinking about sustainability right from the get-go. Just exactly how are you implementing it? Because how you implement it will affect how sustainable it is. We don't really think there's this sustainment phase. That's kind of a myth about how quality improvement works. Sustainment is how you actually implement and make changes and adaptations along the way to make sure you're getting effectiveness out of each component of an innovation. So the things, drift over time. That rationalized violation can happen after implementation as well. Staff turnover happens, leadership changes, new priorities, and people start making small shortcuts. Innovation is something that slowly changes and often without anybody noticing. So these are things that you kind of have to keep on touch of. And even though you've been really successful with it, you need to keep monitoring until you know that the program is really effectively implemented and not just this one-off kind of activities. So the better questions to ask for fidelity versus adaptation, and we could spend several shows on this and just go through each of the research literature on each of those, Project Red and the ABCDEF bundle. But the questions to ask is, why was a step included? What problem was it solving, or what was it fixing? What happens if it's gone? What happens to the whole? What happens to the piece? What replaces it? And are we preserving the mechanisms, the underlying effectiveness of what the new innovation is trying to do? So the debate really isn't about fidelity versus adaptation. It's about using both. It's about understanding when an innovation needs to change and when it can safely change, and what pieces really can't. The strongest implementations team don't avoid adaptation. Adaptation happens all the time because the context is different, the setting are different, the resources are different, the availability of different capabilities are different. They just get really, really good at asking better questions before they adapt. They probably even check with friends and neighbors or other organizations similar to theirs. That's the whole reason why you can't do this quality journey alone. You really need to have a big network, a network of organizations that look like you, that have similar characteristics, that can give you advice about when adaptation works and when they found out that it fails drastically. So the next time your team wants to modify a successful innovation, don't begin by asking, can we simplify this? Can we do it with less resources? Do we have to have the same staff in it? Begin by asking, what problem was this originally designed to solve? And what's really essential in that process? The answer to those questions may determine whether you're strengthening an innovation or quietly dismantling it. Now, if today's conversation made you think differently about leading change, share it with a colleague who's guiding innovation in healthcare. Thanks for listening to Viral Healthcare. I'm Bruce Spurlock, and I'll see you next time.